check on that.
You got it, Dory, thanks.
You're welcome. The Wizard of Oz. I just want to share with you a report. I asked for the state to provide us a report. If you remember last year at this time, we provided you a report that took the 2011, and so we called it 2012 report, but it was the 2011 data, to begin to look at how we compared. And what we did is we created reports that mimic the National Trauma Data Bank, so we could compare Texas to the overall National Trauma Data Bank data. And so they have updated this, and you're going to see this is going to be the 2013 data. And again, this is all registry submissions from the trauma centers. And so again, the summary report includes only data on hospital records that were reported. So we do know that there's hospitals that are still sending data. So again, this will be continued to be updated. So you can see the report will reflect 16 level 1 trauma centers, 10 level 2 trauma centers, and 46 level 3 trauma centers, and 177 level 4 trauma facilities reporting data, which is a total of, well, let's just talk about the non-designated. There's 329 non-designated hospitals, so there's a total of 578 hospitals that have submitted some type of data. And Jane, I think in the meeting today you said there's 600 and something hospitals in the state of Texas. So we're getting close. So you can see this information. So the highest bar reflects 45,000, the lowest obviously 0. So the first column is the level 1 trauma centers, which reported 39,625 injuries. The level 2 trauma centers reported 11,383 injuries. Now remember, there may be data that's still not reported. The level 3 trauma centers reported 27,451 patients, and the level 4 facilities 23,811. And again, you'll see non-designated facilities, and so we do believe some of these hospitals are non-designated or in pursuit of designation as well. So there are 19,933 trauma patients in that group. So again, you can see this is just a different way to look at it. 33% came from the level 1 trauma centers, 9% from the level 2s, 23% from the level 3 facilities, and 19% from the level 4 facilities. And again, that's 16% from those non-designated facilities. So I looked at the data from last year. So last year there were 4 billion charges, so you can see the numbers up slightly. Otherwise, it's pretty consistent from last year's. So if you look at the hospital primary payment source, again, Medicare, 32,750 trauma patients, self-pay, 24,075. Now that sort of mimics the fact that we're always saying uncompensated trauma care in the state of Texas is a huge issue. Now, we have this data from the hospitals, but we don't have this same reliable, consistent data from the EMS to be able to reflect that. So again, if you look annually, reporting currently about $220 billion of uncompensated, $1 million of uncompensated care annually. So if you look at the level 3, the next category would be Medicaid, and that's 13,319. So Blue Cross Blue Shield is 9,922 of those records. So if you look at the condition of discharge from this data, there were 3,064 deaths. Good recovery, 57,801. Moderately disability, 26,279. Severe disability, 1,660. Persistent vegetative state, 16. An unknown, 32,483. So again, as we build reports to look at the data, you can clearly see a lot of us would have questions on that. So we can drill down and find out some of the problems, why this data is showing an unknown, and what we can do to clarify it. So this is the Texas hospitals by age, and then looking again, so you can see the age breakdown, hospitalizations, percent, death, and then case fatality. So again, total, there was 121,303 cases reported. If you compared that to the 2012 report that we had, there were 1,117,000 cases that were reported. So if you look at the mortality, there's 3,261 deaths in this particular report, with a mortality case rate of 2.69, which is lower than the National Trauma Data Bank case mortality rate. So again, if you look at hospitalizations by age, The male, the total is the chartreuse, I guess that's the color you'd call that, lime green. Male is blue and female is red. So you can see the case fatality, the older we get, sorry guys, women take over. So injury severity score by age, again, you can look at the bottom, that's the age. And you can see ISS of 1 to 8 is in blue, ISS 9 to 15 is in the red, ISS 16 to 24 again is in that chartreuse or lime green, whatever color you want to call it, and ISS greater than 25 is in the purple. So you can see the reflection of the ISS scores. Alcohol use. Now we talk about this in this committee a lot. So unknown, 28,927. Confirmed by test beyond the legal limit, 620. Yes, confirmed by test, trace levels, 10,755. Not confirmed by test, 16,807. And then not tested, there were 64,194 that were not tested. So the median length of stay, by the data from the Texas Trauma Registry, you can see on ISS score 1 to 8 is 1 day. 9 to 15 ISS, the average is going to be 4, or the median length of stay. ISS is 16 to 24, again 4 days, and greater than 25 injury severity score, the average length of stay, or median length of stay, is going to be 6 days. And the information that's missing, again, you can see that the group from that category. So what you can do, we all talk about we need a benchmark, and so if you're wondering how your hospital is doing and you're not being able to compare yourself to the National Trauma Data Bank, you're not participating, you can take this data, and this would be a great thing to just test your own system. You know, what's your length of stay in your particular facility based on these injury severity scores. So hospitalizations by trauma designation and age, that looks like a very complicated score. Slide. You can also, when you tomorrow get it off the website so you can look at it more close. The level 1 trauma centers are in red. Level 2 is in that chartreuse green. Level 3s are purple, and level 4s are blue, and the non-designated is in the tan orange color. So you can see the mix on that. The mechanism of injury, if you look at item number 3, falls, 47%, almost 48% of the population that we're talking about is from the falls. And then if you go down, motor vehicle crash is 21%, 21.41%. So those are the 2 large mechanisms of injury that we're dealing with admissions to the trauma center. So you can see again the fall, the first large column is falls, and then the next one is going to be the motor vehicle crash. So this is a comparison of the non-fatal injury categories compared to the top 5 fatal injury categories. So you can see again on the non-fatal, fall is number 1, motor vehicle crash number 2, struck by or against, that's going to be number 3, cutting and pierce is number 4, and then transport is going to, the other transportation, these are your ATVs and things like that, comes in number 5. If you look at those mechanisms that cause death, falls again is number 1, 35%, and the motor vehicle crash 34%, firearms 14%, struck almost 4%, and then other unspecified would be 2%. So our mechanism of injuries, if you want to look at where we should put our dollars for injury prevention, obviously that particular category is where we're going to get it. And again, this is selected mechanism of injury by sex. So the male is in the blue-purple, female is in the red, and then total is going to be in that lime green looking color. So you can see for falls, more females fall. You look at motor vehicle crash, more males crash. Struck is going to be the male population, and that's true for almost all the other mechanisms as well. Hospitalizations by hospital designation levels in ISS, you can see this breakdown. The ISS score 1 to 8 is in the blue. ISO scores 9 to 15 is going to be in the red. And then the lime green color is 16 to 24, and then greater than a 25 injury severity score, 25 or greater, is going to be in the purple on top. So that's a breakdown of the data. Obviously, we could spend a lot of time trying to analyze it. So this information is going to be available to you. Again, you can go to the website and you can pull it down. There's more slides to this, so if you want to get the complete data, you can go to the website and pull that down, and then begin to compare it in your RAC as well as you can compare it in your own hospital. Any questions on the data? Very good. So then we'll go into our work group reports. Almost a year ago, we started a trauma registry work group. The purpose of this registry work group was to create liaisons with the trauma system to address the current trauma registry's development. And this includes all the committees had a representative on this, as well as stakeholders. Our goal is to define the barriers, reports that we really wanted to look at. And so I'm going to give you some outcomes of that. We did meet this morning. So the EMS committee, what they specifically were looking for was the integration and the update into NMSIS 3. In addition to that, to define who is the report. The next thing was vendor communication. And then finally, the business agreement process. So, there was a lot of discussion, I would call it healthy controversial discussion, about if I have a contract with a business, I send, or they pull the data out, they have the data, can they send the data into the state registry for me? So there was a lot of discussion regarding that. So is Brian in the room? Anybody that was in a meeting want to comment on this? Okay. Pediatrics, there was a lot of discussion about child abuse. So the first thing about child abuse is that the E-codes that people are using to identify child abuse it's suspected that it's not correct. So the Texas Trauma Coordinators Forum, as well as this committee, has asked Lori Vinson, who's on this committee, to address this and to provide an educational overview. There was also discussion about whether or not the state registry could identify repeaters and be able to help identify that back to the hospitals. And so there was a lengthy discussion about that. They did not feel like that was doable. So one of the suggestions that I had, and again, this goes back to the RACs, every RAC should have a system PI committee, right? And you most likely have a pediatric committee. So if hospitals could report or identify those patients that they admitted or evaluated that had injuries suspected of child abuse, and then share that information, you might be able to do some of the things that the pediatric committee was asking for to be able to share data. So, just to clarify what the pediatric group was asking is if my daughter, Tori Klein, was taken to Baylor for injuries that were suspected of child abuse, and then 3 weeks later went to Medical City with these suspected child abuse injuries, and then a month later went to Presby with suspected child abuse. The pediatric committee was asking, can you identify that and can you alert us that that's actually taken place? So that means names would have to be identified. So there was questions about that. So the question is there a way to make that happen in the RACs currently to be able to identify and share that through the systems PI committee? So Colin, did you have a comment? Anybody from pediatrics in the group or anybody in the registered work group want to add clarification to that discussion? Okay, stroke was present but had no action items requested. Injury prevention has a data request in to look at the top mechanisms and other activities. Their medical committee had no actions. And then cardiovasculars, what specifically they were looking for is the cardiovascular disease stroke query that has been completed to be sent to that group, and I believe that's already occurred since the meeting this morning. Is that correct? Yes, Chris is shaking his head. So trauma, is Irene in the room? So in the trauma committee, again, these are some of the things that we have asked for. Vendor communication with the state. So we know that we have trauma-based, Trauma One, and DI. And image trend in the state of Texas, right? So the next thing we know is the registry uptake. So there's been some of the registries that as the hospitals are trying to send data in, they've had an upgrade and it's not accepting that upgrade. So that's on the issue to be addressed. And then the other request was DISH deadlines. So DISH is asking us for information, so this group is asking for defined deadlines of when things are needed. And then a user's guide development over this new registry for the state of Texas, and then a data dictionary. So remember, the data dictionary that we should be using at a minimal is the National Trauma Data Bank, and then the NMSIS data. So Irene, you have any additional comments? Okay, so this is what the registry work group is working on. So if you have items that you feel like we're not addressing, we're trying to go through the other committees and bring it to the group, but if we're missing something, please let us know. So our trauma medical director's best practice work group, I don't have a report from Brian. I know that they're still looking at the job descriptions and they're looking at the activation criteria. So Brian will not be back until November, so Dr. Gandhi is going to take on the lead of this until Brian gets back. So anybody that's out there that's a medical director, trauma medical director, or EMS that would like to be involved in this committee, please touch base with Dr. Gandhi. So we're trying to keep all levels, level 1s, level 2s, level 3s, and level 4s involved in this process. So the items that we have specifically selected were common terminology for the trauma medical director job description. We have in the rules adopted the new Joint Commission taxonomy for PI for the state of Texas. So templates for facilities to use, geriatric trauma guidelines, massive transfusion. The other one is telemetry opportunities, telemedicine opportunities in trauma, and then other trauma specific issues. Should I let Dr. Gandhi talk about how he wants to organize this, I guess, in conference calls or?
Yeah, I think the best way is to start.
I know Brian had a couple of conference calls before he left, but.
Yeah, I think the best way to start is by email communication, and then we can get organized the conference calls after that. So my email is on the GETAC committee list website. Otherwise, it's rgandhi, Gandhi, @jpshealth.org. Thank you.
The next work group was the non-physician or the advanced practice provider work group. Kelly, I know that you're in the group. Do you have any comments you want to update us on?
Actually, no additional comments besides this was what our standing topics were from our last conference call. We've not met much over the summer, or actually at all over the summer since the last conference call. Really would probably like to see a little guidance from the trauma medical directors group and perhaps the committee as a whole as to what you want to achieve out of this work group. There were a lot of very talking points, but I don't think we really had clear direction on what we wanted to accomplish out of this.
Maybe you can touch base with Dr. Gandhi and I before after the committee. Wanda, do you have anything you want to bring up from the RAC development? We kind of put that on hold because we thought the surveys were going to take place. No? And Irene, we asked Irene to look at the trauma registrars work group, and specifically what we're looking for is very much like the trauma medical directors, is common terminology and language for the job description for the trauma registrars, organizational structure, the opportunity for clinical ladders. Most hospitals, again, have cancer registries. The cancer registry staff are usually treated very different than the trauma registry staff. And so is there a way to, take what they do in cancer and make sure the same opportunities apply for the trauma registrars? And then educational program needs, specifically looking at the criteria from the state as well as American College of Surgeons to see how to make that criteria and educational opportunities available in Texas. And then the data management needs. Again, part of that's education. Any comments, Irene?
Just as we're going to continue the data management course
know one thing that in the new rules and working with Jane, I think we were pretty adamant to make sure that the AAAM stayed in, but we also had a significant reference to the American Trauma Society's registrar course. That registrar course is very difficult, so the language is being changed, I believe, to appropriate trauma registry courses, so that both of those courses, any of those courses would meet that criteria. But that's in the new rules. Everybody needs to understand the new rules are not out yet, right? The next is electronic medical records. So we asked Courtney and Wendy to address this. And so we're talking about the electronic medical record. We're looking at Epic and Cerner and any of the others that are in the state of Texas. And so there's been a lot of focus on the trauma registry, the trauma resuscitation form. But we asked this group to look beyond that and to look at all the templates specific to help with trauma management within the institution. So Courtney, Wendy, are you here?
So with this work group, we've actually met and have an organized plan. What we're actually chose to do is take it not necessarily from a product by product source, but keep it gender neutral and keep it very broad in the sky. We've listed out all the requirements that we think a functional house-wide EMR should do in support of the trauma program, looking at it from the ER situation, the trauma resus space, the inpatient, the case management, from surveyor standpoint, from also being able to audit, follow up, and PI, and we've gotten all that listed out. We are working through the current lit review and survey of what already exists out there that we can use as reference points, and then hopefully we'll get you a draft very soon.
Thank you. Anybody have any questions for Courtney? Again, if you want to be involved in any of these work groups, just contact the lead and sign up. The pediatric trauma coding, again, this is what we assigned to Lori and to Mary. So Mary, do you have any comments you want to add?
Yeah, Lori and I are going to have identified a single E-code that can be used. I'm sorry, usually you don't have trouble hearing. Lori and I have looked at the E-codes and identified a single E-code that could be available and used for child abuse coding, for suspected child abuse. So we have an email and a phone call tomorrow to shore that up, and you should have something by the next meeting.
Any questions for Mary? You guys are really not talking. Listen here. The impact of alcohol. Carla, Christy, this is yours.
So at the last meeting, we had talked about some of the gaps in the data that were, and actually the slides that you had shown previously demonstrated some of those same potential inconsistencies, and so it's really hard. And so the alcohol data that was on your slide really does show that alcohol testing is not being done exclusively in the state, and so I think that shoring up the data is probably, and entering data correctly, consistently across the state is probably one of the opportunities for improvement, and that is a challenge because of the turnover in the staff and who do that data entry. Recommendations for best practice, we hope to have that to you very soon also. So we continue to work on that, the process for this.
Any questions for Carla?
Just wanted to make a comment. I think one of the items that was seen in that data was also that not enough tests are being done.
Right.
And volitionally not being done. I think that's an insurance issue. That certainly when I was in New York, we had that issue where we were asked to forget to get alcohol levels, because if it was positive, that insurance wouldn't pay for the entire hospitalization.
I believe that rule and that law and the opportunity to do that has been repealed. Courtney, you want to address that?
So with the last legislative session, the uniform insurance code Texas was one of the states that had the alcohol inclusion laws in it. But as of January 1, 2014, the last legislation prohibited that clause from being included in future policies that were created or renewed after January 1, 2014. So the hope is, now that that law has been repealed, that we will see additional increases in testings and awareness by providers, that is no longer a stipulation and that is no longer means for denial of hospital billing and whatnot. So hopefully we'll start to see that number of non-testing decrease because of that barrier.
No, I appreciate it. It'll still be a year to delay, because this year, the effect January 1st was from the prior year's renewals and things, so it'll be at least a year. Okay, thank you.
Jory, I would also suggest that the group put some emphasis on how to change the medical examiner's reports. The death certificate identifies whether or not smoking was involved in the death, but it does not say anything about alcohol. So individuals who were in another vehicle, who are the victim, die on the scene, go to the medical examiner, those are not reported in the deaths related to alcohol, and I think that's a huge gap when we go to the legislature.
Good point, Wanda.
Jory, I also think insurance isn't the only reason that alcohol levels aren't being drawn. I believe that there are many trauma surgeons that don't understand the importance of getting that information from an injury prevention standpoint. They're looking at it from a cost containment standpoint and its additional testing. I've tried to get it added at my facility, and it's I think that's another hill that, from an educational standpoint, that we need to think about.
So Dr. Gandhi, can you add that to the medical director's best practice work group?
Well, Jory, I think along that same line is not just the education in general, but I think that you need to look at all patient populations. You know, you look at, if you take just your typical patient who's the risk taker, you have older adults, you've got not just the young adult population. So I think it's across the board that the testing has to be completed, as well as your teenagers and, you know.
Well, they started well with the SBIRT program,
right?
But I think you got to take it another step further. And I think until somebody pretty much mandates it, you're not going to see 100% compliance with obtaining the alcohol levels.
I think the group, I mean, I'll be honest with you, you're never going to get 100% of anything because people change and new people come in. But I think the number one issue is if we can get our hands around what the true impact is for legislation, I think that would be extremely important. And at the same time, I'm kind of concerned. I don't want everybody to think that every trauma patient that we take care of is a direct result of alcohol. You know, so they come in very different issues. So, but we do need to know the impact of alcohol for injury prevention activities. Jane, do you have anything you want to give an update on this trauma system survey? I know the last time we said it was pretty much on hold. Any new information?
No, Jory, not at this time. We're still on hold.
So we are moving forward with being part of the GETAC strategic planning meeting. So this group was represented last GETAC meeting in May. We had a after GETAC meeting where we talked about the strategic plan. So how many of you have ever read the strategic plan that was produced? Was it 2009? It's still out there?
2002.
2002, wow. So the goal is to go through that and completely update it. So we did have a trauma systems committee, strategic planning, specifically to look at the update needs for the trauma plan back in July the 23rd in San Antonio. So Brian Eastridge has that information. It's been sent in to the leads. I think it's Vance and Dr. Goldberg also were part of that process. So the obviously the outcomes or what was recommended are not published at this particular time, but if you have any major issues or recommendations, if you'll let me know, I'll make sure that those are brought forward. There will be, after the GETAC meeting on Friday, There will be another meeting where the strategic planning meeting will be discussed. So after the GETAC meeting. Anything else, Jane, on that? I don't know where it came from. So again, these are just some of the numbers. I keep adding this to the presentation so people can remember why are we here. Texas road fatalities are 1.41 deaths per 100 million. 230,506 individuals are injured in motor vehicle crashes in 2012. 1,099 individuals were killed by motor vehicle crashes that had alcohol on board. 63,610 critical injuries occurred, while 87,087 serious injuries occurred annually. This all came straight out of the Department of Transportation's website, so if you're wondering where the data came from. Texas rural road fatalities. How many of you drive on a rural road? 55.7% of the road fatalities came from the rural environment. There was no day in 2012 where there was not a death. So again, traffic facts, there's one person killed every 2 hours and 35 minutes in Texas. One person is injured every 2 minutes and 17 seconds in Texas, and there's one reportable crash every 75 seconds. So the question is, who will it be, where will it be, and will we be standing ready? Will it be your loved one or my loved one? So the next thing we want to do is each person on this committee has a responsibility to reach out to other groups. So from GETAC, the American College of Surgeons, again, Region 6, Dr. Stewart is our representative. I don't have a report from him today. He is moving his son to college. EMS, Alex Santos, do you have anything from the EMS group? Okay. David Reeves is not here. Kathy, anything from TTCF?
Courtney can, because she's president, I'll let her do TTCF. But I know with ENA, the 7th edition of TNCC is rolling out. And the failure rate's about 15 to 20% according to Ms. Jenkins at Texas Children's. So they're working on that, and there has been a newer edition with some corrections to the errors in the ENPC book also.
Courtney, you want to update us on the Texas Trauma Coordinators Forum? You might as well sit in that front row.
We met on Tuesday. We had presentations from, the state gave us update reports. We had a presentation from Sam Vance explaining the EMSC program in the state of Texas. Our educational offering was on abusive head trauma associated with non-accidental trauma and that aspect in regards. All of our committees met. We have the level 1-2 committee. We took nominations and elections. We are planning to meet the Friday before GETAC. Our board meeting will be from 8 to 10 that morning, and then we'll have our general meeting from 10 to 4. Focusing on the education at that meeting will be on advocacy and legislative initiatives, what you can do as a citizen of Texas to move forward in a unified approach as we start to legislative session next year. Any questions?
Very good, perfect. ENA, I know Sally's not here. Kathy's given a brief update. Do you have anything? I know Sally appointed you to come.
Exactly. So Sally just wanted to let you know, so for TNCC courses for in 2014 up to March 31st, so far there's been 3,082 courses with 22,481 attendees. Like mentioned, the new edition has rolled out, the 7th edition. It's very long days in it. There's a lot of material and stuff, but it's been very good. As mentioned, the fail rate is about 10% right now, which is actually on average compared to previous versions as well. So that's pretty much it.
Thank you. Pediatrics, anything, Mary, you want to bring up from the pediatric facilities?
No, I didn't know. I didn't attend the meeting yesterday. Lori did, and she's not here today.
Is anybody else from pediatrics here that wants to provide any type of update? Okay. Christy, anything from the level 4s? The only thing that I'm hearing from the level 4s is again the question about the registries and the data. There's a huge issue of not getting data back from the state registry in a timely manner to do things from that data. So I know the registry group knows that, and so they're looking at that Level 3 facilities, Dr. Lopez?
So the only thing is that there's several of the level 3s that are up for level 2s. And I know down in the region I'm in, we have at least 3 that are hopefully in the next 4 years will jump up to that level.
Okay. Level 2s, Lori?
Most of the activity is surrounding the new Orange Book and just discussions there. We have a really good group in TTCF with the level 1s and 2s meeting. We're all just trying to help each other with what's going to be expected, what changes there are, how are you accomplishing this or that kind of thing with practice guidelines and those kinds of things that are relatively new, or people have them and we're going to kind of compare and contrast to make sure the standard of care is kind of the latest and greatest, but that's pretty much all I have.
Very good. Dr. Eastridge is not here, and I, to be honest with you, haven't done anything with the level 1s. Injury prevention.
So today actually TCAA set out their summer newsletter, and they are collaborating with the inaugural Injury Prevention Summit to put on an injury prevention course, which will include options or how-to for coordinators to get funding, not just within the walls of their facility, but applying for grants and things like that. So I think that's huge, because we all know how necessary injury prevention is, but also how costly it can be. So I think they'll be rolling that out, and the summit is next month, but it's in Philadelphia.
I do know that the Trauma Center Association of America, there's a flyer on the counter out there if you've not seen it. Their meeting will actually be in San Antonio this year. I think it starts on October the 29th. They have their general membership, and they have their finance course. They have their trauma medical director course. In addition to that, they have 2 new courses. One is the trauma center leadership course, and the other is the trauma system leadership course. So if you're interested in those courses, you can pick up a flyer. I talked to Jennifer, and there is a discount for people in Texas if you want to go to the Trauma Center Leadership and Trauma System Leadership course. Instead of having to register for 2 courses, you can register for a discounted rate. So if you're interested, you can call her and find out how to do that. So any actions we want to move forward to the GETAC meeting tomorrow? Y'all are very quiet. I think the strategic planning actions that Brian took forward has already gone to that particular group. So that's probably the biggest focus that we've had. The trauma rules are not ready to go. So Jane, do you think we're going to have those ready to review in the November meeting? We'll put that on the agenda.
Yes, put it on the agenda.
Anybody in the audience have anything they want us to put on the agenda for the November meeting? I have never seen y'all so quiet. Any open discussion from the committee members? Any open discussion?
I'll break up the...
Okay, please.
There's a couple of items that are very pertinent to everybody. One is in terms of guidelines. The Orange Book is fairly clear on where guidelines should be. In our state, there are centers that basically go by guidelines, and there are other centers that go by anecdote. And I think one of the points for the RAC system should be to standardize care. And I may do something a little bit different than my counterparts in Houston, Austin, Dallas, but for the most part, we're going to be going by the guidelines for the level 1 trauma centers. And I think we need to put those guidelines across, and the trauma directors group will certainly work on those guidelines, but I think the guidelines need to go not just from level 1 centers or level 2 centers, but across through level 4 centers as much as possible. The next item is actually not just in hospital, but pre-hospital care as well. There's certain pre-hospital guidelines that I think are very important. Dr. Goldberg mentioned it earlier today, and that was really the first time that people have come, pre-hospital providers have come to get guidelines to help them along. And I think that's another area where the RAC system can be very beneficial to the trauma patient at large.
Where do you see the medical directors of the pre-hospital involved in that issue, though?
I think
they're key.
I agree. I think
and that's the issue I feel is lacking in our state. I'm going to be kind of ridiculed right now, but when you have a medical director that lives 400 miles away, from the region he's supposed to be the medical director for, there's no guidance. So in my opinion, it should fall on the medical director of that pre-hospital area.
And I think there needs to be a combination. I think the medical directors are involved in terms of their own area protocols, but I think there should be some standard guidelines for the protocols. And the medical directors must be involved with that because their primary objective is patient outcome. When the patient outcome is not appropriate and either gets brought to me or gets brought to them via me, that's who we go to is the pre-hospital medical directors for their input and their guidance in terms of how do we improve care. So the pre-hospital medical directors must be involved in the entire process. There's no way, and it would be wrong to try and exclude them in the process of getting the standards in the first place. But I think there's so much data out there that we really do need to look at them. Now, a lot of the data is not very good. Having done a guideline for East in the past year, we went through 9,000 articles, and out of 9,000 articles, we got 8 that were really good. So there's a lot of data out there. Not all that data is good. But there are lots of people working on appropriate guidelines, and I think that's where we need to go to and use those guidelines.
Any other comments? Lori? So let me ask y'all some questions. Is there anybody in the audience who has anything they want to bring forward before I start?
I'm supposed to give you another message from Sally here.
Okay.
She says that the PEDS committee expects to have the pediatric transfer consideration documents ready for the trauma systems committee meeting in November as well for your agenda.
I know Lori sent me something from the committee. I'm going to try to see if I can find it. Lori has updates and said that the committee also talked about the community paramedic program. There are several organizations, RACs, that are beginning to support that. So they're going to try to have more discussion on that. The radiology position about exposure has been brought up multiple times. That was discussed. And then EMSC is completing a clinical practice PEDS guideline for EMS that they were going to be sharing with the strategic planning group. So I have a couple of critical questions. So if you look at the new guidelines, the first question I have is we have provided a topic course in conjunction with every GETAC meeting for the last 6 meetings. Do you all find that beneficial? You still want that? Yesterday there were 70 people in that topics course. I know we're also trying to schedule some in some specific regions, but the goal was to have a central location so you knew you could always count on a course being there. So I need y'all to say yes or no, you would like to see that continue. Yes?
Yes.
So are there other courses? Because one of the things we talked about is rotating, having a topic course, and then the disaster management emergency preparedness course that's offered by the American College of Surgeons. So to rotate them, so 1 month, 1 quarter GETAC meeting would be a topic course, and the next would be a disaster course, and then back to topic. Y'all want to see them rotated or try to do them both simultaneously? Now you're stuck.
I think the topic is more needed.
I think topic is more.
If you do one disaster course
quarter, I think that may be too many. I think one every year or two.
Well, I'm going to tell you I disagree with that because I don't think the hospital people really have a clue how to, the whole hospital group have understand how to respond to disasters. It's my opinion. So I think that everybody that's out there needs to take topic, needs to take the disaster course.
We
My
wish our
opinion.
administrations agreed with you.
Yeah, I was gonna say
Right.
the same thing, Tori. I think that the hospitals will see more out of the topic course, and they're gonna say, you need to go talk to your RAC, because don't they get money for disaster? I mean, I think is what they're gonna get told, at least right now. Whether I agree or not, is a different story.
Notice I'm trying not to comment on that. Okay, so definitely topic. Are there any other courses you would like to see?
How about T-CAR or P-CAR?
Yes, I was, that,
Yes.
If we can partner with that group. And of course, AAAM is always something that everybody wants and needs.
Yeah, the data management class.
Is the data management class, Brenda, is that a 1 or 2 day course?
It's 1 day.
Any other courses?
How about the burn class?
And I want to bring up something about burn centers. This is not well thought out, but it's an issue that I keep having in getting follow-up after transferred patients. Timely follow-up. I always get follow-up eventually, but timely follow-up. And then when you really want to talk to somebody about a care issue, it's very difficult to find the right person or to find somebody that will give you the feedback. And I don't think we can improve care. I don't see burn centers really represented truly as a part of the trauma population. And I feel like we could grow better at caring for that population.
Okay. You're obviously sending to 2 trauma centers. I mean to 2 burn centers. So
Yes, that's why.
let's talk offline. Anybody else? Y'all are all happy. You have all the resources that you need. You like everything that's going on in trauma care.
The RACs want more money.
So does Jory Klein, but
Jory, real quick, Lori just confirmed something I forgot to mention, is as we're going across the state doing 3 and 4 surveys, we are finding that they are having challenges getting feedback from the tertiary care facilities. So if it could be, is there anything this group could do to work through that to help the 3s and 4s get some feedback on it?
okay. I want to go back to what Christine said because I was just kidding. But I think the funding issue for the state of Texas is a huge issue. So we worked really hard in 2002 and 2003 to address funding. However, every single day it seems like the funding is being chipped away at some source or another, whether it's at the federal level or whether it's with our own state legislators. So did Dinah leave, Brenda? So we did have a TTAF strategic planning meeting in conjunction with the other meetings that we had in San Antonio. And in that meeting, Dinah was very instrumental in bringing Zerwas to the meeting, who we had opportunity to talk about the 3588 and what it does for the state of Texas as far as trauma care. There was also a huge push when you think about the RACs. I can't say it like Eric says, and so Wanda or Christine or anybody else that's part of Eric's group, Eric gives this analysis of, if you look at the state capitol is a huge building. There are many decisions made in the state capitol. Many resources come out of that state capitol. There's a lot of things that happen there, the lights, the water, the power, and everything that goes into the state capitol, right? But nobody questions how does that state capitol get funding. They question about what comes out of there. So when we compare that to the RAC, there's a lot of similarities. The RACs, the Regional Trauma Advisory Councils, were designed for specific purpose back in 1989. Obviously, they were the brainchilds of Dr. Thal and Dr. Maddox. And I happen to think it was a very smart decision to divide the state into 22 trauma service regions to try to create an infrastructure that could be geographically designed to promote and help with the development of the regional system, right? Does anybody disagree with the 22 RACs? So the question that we really have before us is that with the hospital preparedness dollars going to the RACs, most RACs were pretty good about moving forward, making decisions that really helped the hospitals, the EMS agencies, which obviously benefited the citizens from that particular region. However, the federal dollars are continuing to be cut and cut and cut and cut, and so now many of the RACs are facing huge budget cuts. And I'll let any of the RAC chairs talk about their budget cuts. So what that means is the things that we've taken for granted for many years in the RAC is going to change significantly. So it goes back to that capital concept. So if that was the Austin capital we were talking about, what would we be willing to do without? Would we be willing to turn the lights out on certain hours during the day? What resources? What are we going to say we're not going to do? Well, I personally don't want to stop any of our accomplishments in the state of Texas. So that means that we, all of us, need to embrace and try to go to the legislation for funding. And that funding, for the first time, is not just going to be about trying to take care of all patient care, but it needs to be about the infrastructure to continue the development of the system. And that has to be the RACs. So is there anybody who disagrees with that comment? So we really need people. We can get bullet points. I know Dinah's done a lot to try to get the bullet points out there. I know that she is at the Capitol every day taking home that message. So if you have issues from your RAC, and I would encourage all the RACs to come up with the bullet points of successes that you've had in your RAC and what you're doing to move forward, as well as bullet points about things that are going to be challenged that you may not be able to do with your budget cuts, so that all of that it can be shared with specifically those people who represent you at the state level. So any questions on that?
Jory, I agree 100%. I think one of the data that you showed, the mortality rate of 2.69% for the state of Texas is huge compared to the national average, which is anywhere between 3.9 and 6.9%. I mean, that's a 50% reduction even at the lowest number in mortality. I mean, that's data. If you go with that kind of data, I think it is very impactful. And the other thing I want to say to everybody in the audience is everybody makes that impact when you go down to the legislature. It's not just people that are sitting here or the docs in their white jackets. It's everybody. It makes a huge impact to the legislature when you go down en masse. Last year was 2 years ago, right? Mm-hmm. 2 years ago was the first time that I did it in the state of Texas, and it's still very impactful. We did it in New Jersey as well. But when you see a sea of coats or a sea of people go moving down into the legislature, it makes a huge impact, especially to the individual people there. So, thank you.
Dr. Winchell?
You know, this is a trend that we've seen at the national level at a lot of systems besides Texas. And even at the level of federal legislature, federal what's the right word I'm trying to use, federal bill that has been authorized but never appropriated. The funding is always focused on dollars to care providers, dollars to hospitals. And as you might imagine, that's not an easy sell these days. It maybe never really was. And I would strongly suggest that we think about refocusing, as Jory had brought up, there's a lot more bang for the buck, if you will, in supporting trauma system infrastructure. It's a lot smaller overall amount of money. It's not going to healthcare administration or healthcare providers directly, but there's a big efficiency argument to be made that if you want to control the cost of injury care and make the best use of the dollars that go into it, it's exactly the sort of things that come out of work at the level of the RAC and at the system in promoting the most efficient patient flow and resource utilization. So again, I think it's a good focus to try and change to.
Christine? Thank you, Dr. Winchell.
Christine Reeves, Hot Rack, out of Waco. Dr. Winchell took half of what I was going to say, so thank you, sir. Just a reminder, when we say RACs, when I say RAC, when Wanda and Eric, we don't mean Christine, Wanda, and Eric. We mean everybody in this room, and I'm not sure everybody always remembers that. Just because we are the staff that's doing all the work, but all we are is bringing everybody to the table to make the systems more efficient, which then decreases morbidity and mortality and cost throughout. So Eric would have said it if he was here, so I thought I would pass that on. But it is about the system, and if we try and get out of the word of saying RACs and maybe saying, sorry, Jory, the emergency healthcare system.
No, I'm not going to say that.
You could say trauma.
Okay.
That I think if we start doing that, then as we change that language, it becomes our nomenclature, and then we don't have to explain what a RAC is. It makes sense to people what a trauma system is or an emergency healthcare system is.
I think Christina is right on target, and it's a joke, but I do say the emergency trauma healthcare system. And the reason I say trauma is because when we went there and asked for the dollars, what do we get dollars for? We started the RACs, why? So if we take the word trauma out of it, there's a lot of people going to think, well, what are you doing then if you're not doing that? So I personally go with the emergency trauma healthcare system. So that's why. So that's the bottom line for me. Anybody else have any comments?
Do we have data, so we have a 2.69 mortality rate with the system we have in place. And the biggest fear with the funding is that that system is going to lose the things that we have put together to get to that 2.69 mortality rate. Is there a way to paint the picture of before the trauma system, as we were building the trauma system, and where we are now, and that the fate of the system would be that important?
It's good question. I actually pulled all the old data, and some of you that were around when we started with me will remember that we did several studies. There was a 1988 trauma system study. I have a copy of that. There was a study by John Udell to look at data, so I have a copy of that. And so I've been trying to take the old compared to where we're at and some of the milestones that we've met. But even with all that, I think what we really need to focus on is that I know Wanda could do this off the top of her head, Christine could, Eric could, Rick can, Scott Christopher from his RAC, Terry and them from the Tyler RAC, is to talk about if you're not going to have the RAC system as we know it, with the ability to be that coordinating center, what would go away and what would be at risk. So if it's gone, or if it's at risk for gone, what would be the change in our current system compared to what we're used to? So if we go back 20 years, we had trauma centers. We had EMS agencies. So to a lot of the people that we talk to, they don't know, well, what's been put in place to make these trauma centers and these EMS agencies talk and communicate and plan for this crash, but not just this crash, this disaster, this type of critical emergency, this type of infectious disease process that's hitting us. That's the part that we need to be able to talk about, that right now it's really challenging because we all kind of know it and we think about it, but it's not written down anywhere. Because that's what I see, is when you talk to somebody, they got the idea what a trauma center is. They know what an EMS agency is, they know what an air medical team is, but the process of coordinating the system to get the right patient to the right place, the right responders to the right event, the casualties out to the right place at the right time. That's the part that I see the RAC has brought us together and made us very good at. And so the question is, how do we make that the message? That's the message that I think needs to be told, is how this system coordination, this benefit from the education, the communication, the sharing of ideas that takes place in this thing called the capital for the RAC. Does that make sense to you all? So if there's any of you out there that have messages that can go along with this, or for any of the RAC executive directors that can talk about, you know, this is what the amount of money that we had budgeted, this is what we're not going to have budgeted, and this is what we're going to take away or take off the table, or it's going to have to be challenged, that information would be critical to be able to have to use that in those storylines.
Just to give some more information on what Dr. Gandhi talked about, where we all went to the legislation, you went 2 years ago. It's usually every year, and it's sponsored by TTAF, and it'll be this coming February. So we can all go together again.
But I can tell you this, it's not too early to start planning on what are you going to talk about. Get the data. You know, there's nothing more powerful than the data, because the last time we went, I took these slides and we went into the offices and sat down with these people, and we talked about last year there were 117,000 citizens in Texas that were injured. And we could show them by RAC. This is what we were talking about. These same slides are available to you on the internet so that you can begin to build your story message. Open discussion. Anybody in the audience has other significant questions, comments? Anything from any of you committee members? If not, I will consider closing down the meeting. I just want to say thank you to Dr. Winchell for joining Texas. Thank you, Elizabeth, for coming back into your role. And for those who provided a report, thank you. I also want to specifically talk about Chris and his team. The data that we're getting is, I just want to say thank you. And they send reports, and sometimes I go back and look at it and say, this doesn't make sense to me. I need more information. And so they're very good to work with you. So I just want to say again, thank you very much. We're adjourned.